Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everybody. Bismillah, salatu wassalam ala Rasulullah. And we are starting tonight quite an interesting topic about quite an old medication, which is digitalis. Initially found and generated from plants. And that was actually the only hope for all our patients, not our patients, all the patients at that time. Mainly, it helped improve a lot of symptoms because it has its ability to control the heart rate, so the patient feels much better and so on. But with time, the shining star of digitalis being interrupted by a lot of new molecules that come into the area of heart failure and cardiology. But lately, we find ourselves in a situation that we really need to go back to this old path to support our patients in specific situations. So tonight, inshallah, we'll have three presentations. The presentation will go around the details of the clinical part, the practical part, the pharmaceutical part, and I will make sure that we will not make it long for you. So tonight we have, beside myself, Dr. Rawan Skandarani. Dr. Rawan is a consultant of emergency medicine and medical toxicology consultant at King Fahd Medical City in Riyadh. And originally, Dr. Rawan is from Mecca, and which I recently know. So and also we have Dr. Fakhr Al-Ayubi. Dr. Fakhr is a very well-known clinical pharmacist. She's the president of the Cardiac Clinical Pharmacy Group at the Saudi Heart Association, and she is investigation in cardiology and clinical practice in the Department of Cardiac Services in the College of Medicine, King Saud University in Riyadh. So without further delay, I believe the number of attendance now is 500, almost 600. We'll start with, if you allow me, with my presentation. And okay, so digoxin is okay. So digoxin I'm talking about tonight is the drug that needs to be looked at from the heart failure point of view. Heart failure, we all know it's a chronic condition where the heart is unable to pump blood efficiently to meet the body needs, or unable to pull the blood from the other hand. And we all know the capacity of the disease is really, really big. It's almost 26 to 30 million worldwide. And digoxin is the medication derived, as I mentioned, from the foxglove plant and has been used for over 200 years in the treatment of heart failure. The problem is that the heart failure major public concern that it does affect the quality of life and the longevity. So we know that major diseases like depression, inflammatory bowel disease, malignancies all affect the quality of life. But unfortunately, studies has shown that heart failure does affect quality of life more than all these medications. In the States, heart failure account for over 1 million hospitalization. And in Saudi Arabia, we have almost 1 million diagnoses of heart failure if we consider reduced and preserved ejection fraction. And the effective treatment options for this disease are crucial in improving patient outcome and reducing costs, mortality, and improving quality of life. Now, digoxin has quite an interesting history because it was first isolated in the early 19th century. by a scientist called W. William Withering. So it gained the popularity in the treatment of the heart failure, obviously because it was the only one. And from the scientific part, it has this positive inotropic effect as it was believed. But we believe more and more that the most important part of digoxin is the way that it controls heart rate and allows the heart to adjust its filling pressures, and this will lead to improvement of symptoms. Now, over time, digoxin has become a cornerstone in the therapy of heart failure, and until recently, where things have changed. Now, digoxin inhibits the sodium potassium ATPase pump, leading to increased intracellular calcium level and improved myocardial contractility. And the positive inotropic effect of digoxin help to increase cardiac output and improve symptoms of heart failure. And in addition, it directly affects on the heart, as digoxin can modulate neurohormonal pathway in heart failure. Now, we all know that digoxin also works on the AV node, and it improves the heart rate through that way. Now, from the clinical trials point of view, we have the DIG trial, which is a Digitalis investigation group. It did show the reduction in hospitalization. And we have the PROOF trial. It demonstrates improvement in exercise tolerance and symptoms in patients with heart failure. Now, multiple studies have shown that digoxin therapy can lead to improvement in ejection fraction, but we know that this part is really not our main target in modern understanding of heart failure. Now, meta-analyses have compared the benefit of digoxin therapy in reducing hospitalization, but failed to do that in reducing mortality in this group of patients. Now, the use of digoxin is now specifically indicated in certain subgroups, such as patients with heart failure and atrial fibrillation, and as well as specific groups in which we use a second and third line of anti-failure for a continuously symptomatic patient. Now, the evidence supporting the efficacy of digoxin continues to evolve with the ongoing research and guidelines. Now, the recommendation, as I said, it is based on individual, so it is not like a first line for heart failure patient. It does have an individuality indication, looking at age, renal function, and weight, and then we look at the passing the 4 pillars and persistence, either uncontrolled heart rate in atrial fibrillation or uncontrolled symptoms despite using all the medications in the guidelines. So it is well understood that lower doses and monitoring serum digoxin is very important to avoid toxicity. Now, we know Van Gogh has, I believe, digoxin toxicity. That's why he painted everything yellow, they say. But regular monitoring of potassium level is also crucial in renal function, and we all also know that low potassium in digoxin is quite a problem in inducing toxicity. Now, the issue is that we give diuresis, and diuretics takes the potassium away, and this just increased the possibility of digoxin. The common side effects of digoxin includes gastrointestinal symptoms such as nausea, vomiting, and loss of appetite. And usually with heart failure, these symptoms are common regardless digoxin uses. So it is quite common to be missed if patients start complaining of gastric issues, because he has complained about it before. Now, also it can present as visual disturbance, as I mentioned, confusion, and cardiac arrhythmias, and this is where the danger part comes. Now, the management is always related to, okay, let's hold it for a few days, decrease the level for a few days, but sometimes we really need to use specific antibodies as we gonna learn in the coming couple of lectures. Now, monitoring digoxin level is the cornerstone when you treat patients with digitalis. The serum digoxin level needs to be regularly monitored and need to be between 0.5 and 2 microgram or nanogram per mils. Now, factors like renal function, drug-drug interaction, volume status also can affect these levels. And there's always a simple way in controlling digoxin level, is that measuring the effect of it, which is the heart rate. So you need to keep an eye, keeping the heart rate in the 60s, taking care of a Holter monitor probably every once in a while to make sure that it doesn't dip during sleep. And this is actually one of the first early prevention methods to prevent this toxicity is following heart rate. It interacts with through clearance or binding to proteins. The common medication is usually the one we use, the diuretics, calcium channel blocker, various antiarrhythmic medication. And as I mentioned, monitoring is quite important. Now, the most important part in digoxin is just like the most important part in treating patients with heart failure. We need to educate our patients. We cannot just pretend that our patients understand or know their side effects of their medication unless they are very well educated about that. So having some time with your patient, giving your patient the opportunity to be exposed to your patient educator, all these are crucial in prescribing digoxin for our patients. So they need to be very well educated for the signs and symptoms of toxicity. And they need to have open access if they want to report any of this. And they need to be empowered to talk about it and mention it. And believe me, this is the way to survive any heart failure patient, is to educate the patient and more and more. Now, the current guidelines, the major ongoing or current guidelines use digoxin as a second line and sometimes a third line for medication. And it has an important role in conjunction with other heart failure medication as the cornerstones, as I mentioned, especially in atrial fibrillation patient. And ongoing updates on guidelines will support this more and more. Now, the important part of decrease hospitalization or improve exercise tolerance is actually the quality of life. And not every medication we use needs to improve mortality, but really it's not how long we live, it's how we live it. And this is the cornerstone of digoxin in our clinical and current preclinical practice. So symptoms like dyspnea, fatigue, and exercise tolerance can improve significantly with initiating digoxin and controlling heart rate. Now, ongoing research is exploring the new indications for digoxin use, such as a patient with persistent ejection fraction, HFpEF, which has preserves ejection fraction. Combination with novel treatment now actually also being examined, and update in the guidelines will come without. It is a very, very cost-effective medication. It's quite cheap, the digoxin, and effect is totally away from its price. I mean, its price is very low and the effect is quite high if it's used in the right population. Case studies, as I said, as I mentioned before, is very important. It's not a medication for everybody, but if it is for somebody, this somebody will really improve and really benefit from it. Now, the challenge is adherence, side effects, and education, as I mentioned before. And as I said, sharing decision-making is the cornerstone when you deal with your heart failure patient. Now, in a simple way, it is an old, well-known medication. It still have a role in heart failure management, especially in reducing hospitalization and controlling heart rate in atrial fibrillation, and both of these will contribute to improving quality of life. And by this, I think I passed my time by 1 minute, but thank you very much for that.
يعطيك العافية Prof. Kamal. Thank you very much.
Can we have the slide, please, so we can go on with the Kunuz, please. Kunuz Ritash, can you give us the slide? Okay, so the second presentation will be by Dr. Rawan Skandarani. And as I mentioned, Dr. Rawan is a consultant of emergency medicine and toxicology, clinical toxicology at King Fahd Medical City. Now, diagnosis and challenges associated with dish toxicity will be our next topic, and we will conclude with a presentation from Dr. Fakhr Al-Ayubi, inshallah Rabbil Alameen. So, Dr. Rawan, the screen is yours.
تمام. يعطيك العافية Prof. Kamal. Thank you very much, and it's my pleasure to be with everyone here. This is talking about diagnosis toxicity of the digoxin from the point of view from the toxicology is a very interesting point لأنه it is not that easy and it is من جد challenging. You honed for me you introduced for me the floor على أساس إنه we start looking into the digoxin and I know it's a medication that we use من زمان but it is like you mentioned it is missed because of the difficulties في subtleties خلينا نقول in the overdose يعني it's not that easy to pick up the overdose حقته فأنا will go through إن شاء الله this and I hope everyone will find it I promise you and إن شاء الله you'll find some one or two at least very important principles بالنسبة للdigoxin after this presentation. Like I mentioned, I work in King Fahd Medical City. I'm actually emergency medicine, so it's a kind of a different specialty, but my main passion is medical toxicology. We will deconstruct the thinking approach بالنسبة للdigoxin. When you have a patient that presents to you, wherever you are, with these vitals, it is important في راسي كده when I think about it, I have two approaches, two categories. I will think either حيجيك ممكن المريض on digoxin يا حيكون someone who is something like 25 years old, medically free, intentionally ingested the digoxin. This is one category. The second category اللي هي يمكن more commonly seen أو subtly challenging اللي هم اللي يكونوا more elderly people with lots of comorbidities زي ما ذكر الدكتور كمال Prof. كمال with the heart failure it's still used أحيانا because of it's cheap أحيانا because of يعني it is still seen احنا جينا في era at some point كان more common أكثر يستخدم الdigoxin I've witnessed multiple يعني cases الآن قل نوعا ما اللي هي الكرونيك لأنه استخدامه قل عن أول ولكن ما زالت موجودة please this is the goal of our presentations here to emphasize that when to consider how to look into the toxicity of the digoxin. غالبا تكون presentation وحنذكرها حنمشي very كده subtle, non-specific, dizzy, poor appetite, fatigue. He's already have a baseline of hypertensive diabetes, AF, CKD, and please حط كده 10 خطوط تحت السي كي دي. طيب الابروتش بين الاثنين حيكون شويه different. It's kind of easier لما يكون acute أو intentional ingestion ويجيك ويقول لك والله أنا I took this digoxin وحجيك بس مو بس digoxin cardiac glycosides حجيك هنقول على why what do you mean by that. أسهل من suspecting it. نوعا ما suspicion يحتاج إنه تكون you have a high clinical suspicion high index كده في suspicion في أي مريض يجيك that you cannot explain his symptoms. طيب يمكن بروف كمال ذكر نوعا ما الميكانيزم of action. هو he made صراحة the floor easier for me لكن I really think it's very important. I like to simplify things. If you don't know me when I present, I really like to simplify things and I really like the visual kind of presentation. So we want to really look into the mechanism اللي ذكرها بروف كمال. فإحنا هو الديجوكسين it blocks the sodium potassium ATPase and we know that the base طبعا أتكلم على audience I'm sure you're more expert than me in this بس I really need to hone it لأنه لها دخل في التوكسيستي حقتنا. إنه الكالسيوم هو اللي يكون الانتوبلازميك كالسيوم من داخل الخلية هو اللي يسبب myocardial contraction not only the entrance of the calcium من برا. طيب الصوديوم بوتاسيوم ATPase عشان بس ما عشان الوقت لكن I think it's just important إنه we remember when it gets blocked by the digoxin it blocks indirectly the calcium exchange. طيب and this is how الأينوتروبي حقنا يصير where we have over time the calcium is ما بقول trapped بس البumps تصير شوية overwhelmed by the inhibition هذا. And with time هيصير عندنا more calcium inside and this is the basis حقت why how we use it in the heart failure for contractility وكده. ولكن in the toxicity when we think about it I want you just to look at this and remember إنه we have increased automaticity decreased conduction. طيب I like to simplify things يعني I really think إنه it's very important إنه we remember the major يعني how does it work لأنه هذه كلها التوكسيستي اللي نشوفها depends على هذا الميكانيزم. Remember please إنه في الكرونيك طبعا هذا بنتكلم في الكرونيك أكثر من الأكيوت it overwhelms the pumps يعني with time with accumulation بالذات لما قلنا ما يكون عندنا CKD المريض اللي what happens إنه it gets overwhelmed so you can see the digoxin اللي هي red هذه molecules you will see it overwhelmed للpumps كعموم. طيب زي ما ذكر بروف كمال إذا عندنا hypokalemia إذا عندنا electrolyte imbalance إذا عندنا hypomagnesemia renal impairment this exacerbate the possibility that the patient will present with the toxicity. حتى لو إحنا بنتكلم يعني حتى monitoring the level إحنا we look into the numbers وأحيانا زي ما ذكر بروف we have the textbooks دائما تقول لك 0.5 إلى 2 بس كثير من التوكسيكولوجي في experts we consider above 1 with the right clinical suspicion يعني إذا you have a patient you cannot explain his symptoms with this risk factors please consider it as toxicity. Could it be the digoxin that's causing this حتى لو الليفل أقل من 2 definitely above 2 في الكرونيك most likely ما بقول definitely بس most likely yes it does have some effect on the patient. طيب how do we diagnose it? general concept وهذا نرجع back to الكاتيجوري اللي هي acute لأنها خلينا نقول ما بقول أسهل بس it's straightforward. If you have more hyperkalemia and bradycardia with the setting إنه المريض ذكر في الهيستوري في البرزنتيشن في السسبشن يعني دائما نحن نرجع back للبيسكس حقتنا اللي هي الهيستوري. anything that have suspicion قال لك he ingested it he didn't admit he have a suicidal intent suspect cardiac glycoside. وليش أقول cardiac glycoside ذكرتها في البداية لأنه I want just to hone نقطة إنه it's not only the pharmaceutical digoxin. I know إنه إحنا we're as كذا medically دائما الأشياء اللي نعرفها هي pharmaceutical digoxin اللي نستخدم how we're treating المريض على tablets already بس cardiac glycoside and موجود يعني زي ما ذكر بروف كمال it's أصلا هو من مستخلص من الفوكس جلوف so هو معروف من زمان والناس they know يعني في Asia they know this is it's a common form of suicide مو بس في AG، أنا بتكلم هذا عشان it's common هناك يعرفوه. it's commonly البرزنتيشنز اللي تيجي، يمكن إحنا عندنا هذه موجودة تشوفها في الشارع، في موجودة في كل مكان عندنا. الأولندرز it's very beautiful, they're very beautiful, but they are very toxic and ما بقول lots of people, but people know how to use it if they're really intending for suicide. So please consider this as a presentation. في كمان واحد part من عشان لما ذكرنا cardiac لأنه هي plant based and في عندنا كمان animal based. ما هي منتشرة كثير عندنا، ولكن I've faced few cases because this is kind of بعض الدول يسموها licking pods, kind of a practice على أساس they think it gets you high, they think لها دخل as an aphrodisiac treatment, aphrodisiac kind of شيء زي sexual enhancers. ف they do بعضها, they crush it powder. يعني I've faced one of the cases where it's supposed to be used as a treatment, طبعا herbal treatment locally, and the patient mislabeled يعني instructions اللي given to him and used it as a ingestion. فهي presented طبعا severe digoxin toxicity. فهذه من presentations اللي تيجي. just keep it in the back of your mind. If you faced it, you might need to consider it and just know that digoxin is not only, we're talking about the cardiac glucoside, not only about the digoxin, there's lots of other forms of it. طيب. زي ما ذكر بروف كمال it's not that easy, it's very subtle. لكن nausea, vomiting, photophobia، بس أنا عشان الوقت أحاول ما أخذ من وقت دكتورة فخر إن شاء الله. nausea, vomiting غالبا تحدث within 6 hours. زي ما ذكر photophobia, yellow vision، يميل إنه they have زي يقال بالنسبة لفان كوخ إنه هو this is the reason why he have the yellow painting. فحطيت صورة example هنا عشان بروف كمال اللي حط لنا هي. dizziness, seizure, fatigue, non-specific symptoms. نرجع اللي ذكرناه. بس I want this يمكن that this is هذه important بالنسبة لي إنه أحاول أخلصها قبل ما يعني bear with me. This is how I think. I'm an ER، ولكن as a toxicology حقيقة whoever اللي told me this ما عاد نسيتها بعد كده. I think of the heart as the compartments, atrium, ventricle. In between we have the AV node. صحيح؟ So what happens في digoxin في toxicity? Imagine it being stimulated from الاتريم لحاله والventricle لحاله، ولكن we are blocking the conduction in between. طيب. Please remember this. I promise you. تدعي لي في يوم. This is what happens. So any type of arrhythmia, this means any ECG other than can be seen, except you will not see في digoxin rapidly conducted supraventricular rhythm. طيب. So عشان بس again مرة ثانية. Stimulated can be من أي arrhythmia in the atrium, supraventricular, أي arrhythmia ventricular، ولكن it will not be conducted supraventricular. يعني ممكن تكون ventricular arrhythmia، ممكن تكون VF، ممكن تكون كل anything can be، ولكن it's not be بالdigoxin rapidly conducted supraventricular rhythm. طيب. anything else can be seen, any arrhythmias. وهذه من الكاركترز اللي جدا مزعجة بالنسبة للdigoxin لأنه you cannot specify anything. Most common PVCs, non-specific, bidirectional. If you saw it, it's more linked with ما بقول diagnostic ولا specific، ولكن تميل إنه yes, so in the right settings it can consider with the digoxin. For the time, this is kind of a textbook finding. They always mentioned in the textbook. If it's there, it's there. If it's not there, كان بها. يعني ما أخذ عليها كثير صراحة. Please remember this اللي ذكرته أول. هذه كل الاريثميز اللي كان present. This is what you remember, please. طيب. Can we use the level? Yes, it's helpful. ولكن please don't depend على النمبرز لحالها. It should be just كذا to keep it in mind. It should be 6 hours after the last dose. يعني حتى لو جاء هو acute ingestion أو جاء with chronic toxicity you're suspecting it, make sure إنه the last dose كانت 6 hours لأنه قبلها شوية it's not reliable. It's just عشان the level of distribution حقت digoxin. دائما think of the clinical. Basically the history is your baseline. Take the history, make sure إيش اللي حصل, and keep ask again in the history. إذا كل ما كان level فوق 2, this is more toward مع the right clinical settings. I really consider حتى لما يكون above 1 if I have the right presentation أو case أو يعني I cannot explain, I don't have another explanation. طيب. By this نيجي إن شاء الله. The treatment is always think of DigiFab. digoxin antibody fragments. يعني في كثير أشياء نقدر نتكلم عنها on how to treat إذا كان في arrhythmias إذا كان في electrolytes yes supportive care electrolyte management ولكن if you suspect it أو you know it أو يعني you have a high suspicion دائما consult police toxicology we have great colleagues دائما they are very helpful لأنه it's not easy this is a multidisciplinary kind of challenging cases ولكن the use of the digifab I think Dr. Fakhr الآن and I will leave for her the floor لأنه she will tell us when to use it and how to use it لأنه فيها كثير تفاصيل I'm sure she will enlighten us إن شاء الله بإذن الله in the next presentation. And by this, and I finish, I hope إن شاء الله ما أخذت 1 minute إذا ماني غلطانة برضو above my time. Happy always to take any consultations, you need advice, you need anything. This is my email, please always, I'm always available. And if you need toxicology backup, officially we have a 1937, this is always available. My medical colleagues, we're always available. But this is just to keep, no, it's not easy صراحة. And by this, inshallah, let me stop sharing and we'll go, inshallah, to the questions in the end of the presentations. تفضل يا دكتور فخر إذا موجودة.
يعطيك العافية دكتورة روان. Very nice صراحة introduction for my coming talk. And Dr. Kamal made it also easy for me as a cardiology specialist pharmacist. Actually, you touched base on a very important points, which actually we are trying to emphasize on, especially after we talked about its role in cardiology. I remember when we were talking about this webinar, I had lots of very actually, well, let's say funny comments. They were telling me, oh, is this drug still alive? Well, yeah, it is still alive. And you saw that with Dr. Kamal. Dr. Rawan, thank you very much, because diagnosing toxicity is not easy. And I can tell you that with my 10 years experience in the Drug and Poison Information Center in King Khalid University Hospital in Riyadh, where I was the supervisor of the Poison Center. I have a board, of course. I was running this by a board. I could not do it with pharmacy knowledge only. And maybe it's important just to emphasize that it's a teamwork. And part of my interest, being a toxicologist by pharmacy background, is to understand how these drugs works when it becomes in the toxic level. We used to know that pharmacokinetic, pharmacodynamics are important, but we don't much concern about the pharmacotoxicology part, which is very important. In Saudi Arabia, and I know since I started my pharmacy studying, that we had about 11, maybe now it's almost like 15 poison centers around the kingdom. And where I was trained in King Khalid University Hospital, it was maybe the first or the second. It's not the number. It's the way that we used to treat our patient. It was a toxicologist, emergency physician, with, of course, the concerned ICU physician, depends, of course, on which stage is the patient in, and also a clinical pharmacist, where we have to take a decision altogether in order to see when to start the GFAB, and how to start and when to stop. And this is very important. So I'll try my best, of course. You all know that it's only 15 minutes. And mashallah, I see that the audience are really interested in this topic. And because they give me the complicated part, I'm trying my best now just to go in a smooth and a very simple way to cover about some facts about the toxicology part, and also about the antidote itself. It's very important to know about it, and what's the role of having a team, a multidisciplinary team, in managing the patient. Because in the end, we saw that digoxin is important for specific patients, and it doesn't have an alternative. So what's next? Teamwork is important. Number of cases. Now we can see that the most important part of digoxin, it comes from herbs. And most of our concepts on treating our patients with herbs is that if it's not gonna give you a benefit, it will not harm. This is not true, because even herbs, they are toxic enough to kill even a big elephant, sometimes if they take a high dose of digoxin. So the point here is that we have to know that digoxin started a long time ago. It's not something new. Lots of studies has been done on it, but still the main concern for us is the toxicity. Now, they formulated, of course, digoxin tablets from the digitalis glycosides plant, and compounding its medical dosage form, let's say, was maybe more now than 30, 40 years back. But still, we are facing the problem of toxicity. Now, as Dr. Rowan thankfully said, that we have the Digibind, which is the specific antidote for digoxin toxicity. Not each toxicity of digoxin needs an antidote. And this is a very important message that we want to transfer in this conference. The other thing is that even Digibind or Digifab, Digibind is not there anymore. It's Digifab. It has been approved by the FDA in December 1993. At that time, we had to do some training for that. And I remember when I started my toxicology training, that was in the beginning of these 2002, 2003, they told me, leave this topic till the end, because it's not just knowledge, it's knowledge and skills. So you cannot decide exactly what to do unless you see the patients and the clinical features of the patients, because Digifab will bind to the extra or the free digoxin in the patient's bloodstream. And this will stop the side effects, which is, as Doctora told us, the arrhythmia part, the killing part. And also, it's very important to stop it in a very sometimes quick way, so you can save as much as you can from the patient's heart. Now, again, the important thing is that, as I told you, you need a decision maker for you, and you need an expert for this, because sometimes what you consider as a toxicology part, it could be not from digitalis, and sometimes even the level is a little bit borderline, but patients are really suffering from toxicology of digoxin. So again, lots of levels has been mentioned today, but again, we have to just justify that when we have male and female, also the levels are different. You might consider 1 is a toxic level for male and 0.9 or 0.8 for female. So there's nothing called a definite actually level. It depends on the level on the top of the sign and symptoms. Now, again, how it's produced, it's exactly coming from a sheep. They took the antibodies from there, and again, formulating and purifying the products made this Digifab available for the clinicians to use. And as you can see, coming from an animal source, it's gonna for sure stimulate the patient's immunity. So having this in mind will let you know exactly what to do later on when we are putting our patients on an antidote or antibodies from this kind. Kinetic is important. Why? Because I know some of our colleagues, especially in cardiology, what they do sometimes, they just know that the patient came to the emergency with, of course, the quick action of having a level. They will go ahead and start asking for a digoxin antidote with their colleagues in the emergency. Now, what we need to understand is that digoxin by itself, it needs time to be distributed in the bloodstream, which means that I need to know what time did I take the level and correlate it with the ingestion time. It's very important. And I know myself, I had different actually information from our colleagues in the emergency department. And then when we match it with the patient level, we discovered that the level time was different. So it's very important to know, did your patient take it chronically or acute? Did the patient take extra dose or multiple doses? The most precious information for me is the kidney function. Why? Because this will affect not just the digoxin itself, also the Digifab. Statistic I remember last year, statistic in the poison center, the number declined maybe to not more than 20 plus cases. And some of them were actually more of them were chronic use of digoxin. And this tells you that still the use of digoxin is there and still the problem is there. But again, dealing with the patient properly, taking the decision in the proper time really made our life easy. We all know that when there is a way to start treating the toxicity of a patient, of course, you try to remove the medication from the GI system. But again, lots of other methods like dialysis and hemoperfusion and so on. But we are concerned now about DigiFab. So now what I'm trying to tell you here is that it's not always jumping into DigiFab. You have to think before you jump there. Why? Because again, lots of elements will control this for you. Let's see. When should I start it? And how much should I give to the patient? I know some of our colleagues, they just keep on asking for more vials. Wait, you have to do some elements, some tips before you do that. On the other side, how quick should I take an action? Finally, when should I stop giving more vials? So again, in cardiac arrest, there's no doubt. You go ahead and you do it, okay? So again, this is not an area of grace. It's very clear and it's a very definite decision. But in life-threatening features like ventricular arrhythmia, if you have a patient with hyperkalemia more than 6.5, if it's hypotensive and with, of course, an organ damage or dysfunction and high degree of AV block, in this case, this is where you have to start asking for DigiFab. Another important thing for us is sometimes even the serum digoxin level, if it's taken in the proper time. The half-life of digoxin is from 4 to 6 hours. Now, if the patient took a large amount and it's an acute ingestion, I'm going to expect this to happen within 4 to 6 hours. And usually these kind of levels represent what's in the bloodstream. But if I have a chronic patient and this patient came to the emergency with the signs and symptoms, but at that time, the patient was taking a level 2 hours or 3 hours, and you will think that this is not the proper level. It's not right because it's a chronic level. So I'm expecting this to happen. I'm expecting this to happen even before the 4 hours. So this is very important information that we are sharing. Of course, very important for me also to look at the arrhythmia part. It's actually the guiding key element for such indication. Severe cardiac arrhythmia, hyperkalemia, as I told you before, the GI symptoms. That represents that there's a huge amount of digoxin inside that we have to antidote it before it goes to the receptor, and the digoxin level. Is this important? Of course, clinical terms about this. What do I mean by that? If I have a patient who is considered to be having a suicidal attempt, or even by mistake, they took 10 milligram or more of digoxin as one dose, one shot, or 4 milligram for a healthy child, that is considered toxicology part to jump in and consider a toxic or severe toxic case that we have to introduce the DigiFab to. What about chronic ingestion? In this case, you could see now the levels are different because we're talking about chronic exposure, which means that what's chronic in acute is different in chronic. Another also important part for me is the digoxin overdose levels, the severity of the side effects, or actually the toxicity part. When I have 2nd or 3rd degree heart block, again, this is where you start your DigiFab. And another thing, sometimes when you are exceeding the 5.5 of level of potassium in adult patients who are exposed to a chronic exposure to this medication. Now, you could see that what happened exactly is that DigiFab will compete on the receptor and stop the digoxin from binding and going inside the cell, which is exactly what we have been listening to presentations before I presented. So what happens, they will compete, they will bind with the extra digoxin, but what happened is that they will not, there's no limitation, they will not stop, like after this extra amount, they will stop. They will keep on binding to the extra free digoxin, which means your patient who really need this medication, in this case, will have an under or a subtherapeutic level of digoxin. And that will guide us to the coming few slides, is that, am I doing a good job to this patient? All the studies prove that life-threatening toxicology or toxic part of digoxin is well managed by the DigiFab, and more than 93% of our patients were saved by using this antidote. So again, we need to combine the extra digoxin, even if you are going to an unpredicted level or even a subtherapeutic level of your medication, you're fine. You are saving these patients from killing arrhythmia. Another important thing is for us, we have to do some kind of exercise before we ask for DigiFab. Why? It will guide you again to the second part of this presentation. When should I stop? When should I stop asking for extra vials? You have to measure the serum of the digoxin, and this is a baseline. So you start with a digoxin level before you ask for a DigiFab. You have to also do the baseline of electrolytes, which is very important indicator for us. And of course, the kidney function is so crucial for digoxin and for DigiFab. Of course, liver function is very important for us because this is where the drug would be metabolized and would be active. Complete blood count is important again, and that's why, because we want to see the side effects also on the hematological part. Now, the most important part for me, I have to do this baseline, then ask for DigiFab. What about neutralization of this medication in the bloodstream? Most of the schools, they will run into not doing a full neutralization. They would like to have a partial. But to do that, you have to be so competent to ask your colleagues when to stop. Otherwise, they totally neutralize the free digoxin, and then they start again. This has rules and has equations and regulations, but again, dose of digoxin could be, in this case, known or unknown. If I have a specific amount of digoxin and I know how much amount my patients took, I will calculate the vial according to the amount ingested in milligram and multiply it by 1.6. Another exercise is if I know the serum, not the amount, the serum of digoxin in nanogram per ml, I will multiply it by the patient body weight in kilogram and divide it by 100. So again, the total of number that will come, it's the number of vials. Number of vials is very important because again, we're gonna tell you later on how you're gonna apply it on the patient. Another very important instructions that I would really like to transfer today is that I'm talking about an adult patient or a child that's more than 20 kilo. If you have a patient who's less than 20 kilo, that's another story, maybe another webinar. But again, these are an exercise that's easy applied. If you just try 1 or 2 or 3 times, you will find yourself so competent that you can do it yourself. I told you that the way that patient has been exposed to digoxin is, again, a key element for us to decide how many vials should I give and how should I give it. If my patient has an acute ingestion and I don't know the amount that they took, in this case, what they advise us to do is that you administer 20 vials. Again, 20 vials, each vial contains of 40 milligram. So 40 multiplied by 20, it's 800 milligram. I'm going to do it directly and just give it to the patient. It is not the way. You divide it into 10 and 10. First, initial 10 vials for an acute ingestion of an unknown amount, and then you wait for the patients. You follow the instructions that I'm going to say in the coming few slides. You monitor the patient 6 to 12 hours after the ingestion of the first 10 vials. According to that, we can see if the patient is already okay, there's no sign of symptoms. I'm still monitoring the ECG for the patient, monitoring the electrolytes, the kidney function. That means I'm okay. If not, I have to give the other half. So if I have no clue about the amount, if I know the amount, as simple as that, you just calculate it according to the digoxin level. So this is important for you because it will give you an instructions what to do in acute attacks. Now, what about if my patient is a chronic user? Like what Dr. Rawan said, if this patient is more than 1 with signs and symptoms. So in this case, what happens, you are going to take the digoxin level and you're going to calculate it according to the level. Now, most of the recommendations are telling us if you have an adult or a child more than 20 kilo, you give 6 vials for those patients. After these 6 vials, you would wait again, as we said before, 6 to 12 hours, monitor the signs and symptoms, see the toxicity part. If it's over, that's it. If not, you're going to have to repeat it again. If you know the amount, it's very easy, because what happens, again, you will calculate the serum level, as we said before, with the body weight, and then you divide it on the 100. So as you can see, when you simplify things, it's easy to apply, easy to take care of, but you have to know which one you will apply on your patient. There's another very complicated cases sometimes, the ones that have acute on the top of chronic. And this happens most of the time when you are trying to save heart failure patients, for example, and these patients are going into, for example, a rate problem, arrhythmia problem, and you have no other options to do. In these patients, again, you will have to take a decision of acute on the top of chronic. What do I mean by that? I mean by that the management of the patient, you don't wait for a level, you jump into the vials, give half of the vial, number of vials, and then after that, you will continue with the extra. And now, 1 second, wait. Usually, sometimes what happens, we can give even a half a vial, half to 20 vials, okay? Now, what is the indicator here? It's either the level or the sign and symptoms. You can go up to 20 vials, but in this case, you have to monitor the level. So what happens here is that I'm going to wait for 6 to 12 hours, ask for a level again, and give the other half. And sometimes what happens is that you go ahead and you stop with the first dose. Not to make it difficult for you, it's as simple as that. You're going to see the patient's amount. If you know it, match it with the amount and level. If you don't know, assume the amount and give the vial. How do we prepare it in the pharmacy? As simple as that. You just put 4 ml of sterile water inside the vial. You just take it again and put it in the 0.9 sodium chloride injection. There's different way. Either you give it as an infusion with a slow rate, like 30 minutes, or sometimes if you have a cardiac arrest patient, you go ahead and give it as an IV push. That will lead to, of course, a kind of anaphylactic reaction sometimes if the patient's allergic to this medication or its product. And in this case, we have to be careful and we have to know how to manage. Now, very important that these solutions has to be given now on spot. So don't dilute the vial unless it's needed. And we can wait up till, I believe in pharmacy, we used to give it either now or within 4 hours. If not used, discard. So that's why it's very important for us when to dilute and when to send to the patient. If you have an infant patient, usually we don't give a big amount. We might even sometimes use a tuberculosis small injection in order to give the antidote through. Very important for us is if you're going to dilute it with normal saline and try to keep it, of course, clear, not turbid. It has to be a clear solution when you give it to the patient. There's specific warning, let's say warning or recommendations. If you have a patients that are poor cardiac function, they might deteriorate as a secondary of withdrawal of inotropic effect of digoxin, because as I told you, you're not predicting how much you are removing from the digoxin from the blood. Another thing is that sometimes it causes dilatization, because sometimes you have to, after you finish the antidote, you have to admit the patient in the hospitals, make sure that their kidney is fine, no sign and symptom of toxicity, restart digoxin again. In this case, what happens, I have to make sure that I'm giving it properly, and again, going back to the therapeutic level where your patient needs. Anaphylactic reaction is a very crucial point. Patients with allergy to sheep protein or papaya or these products, they have to be careful, give it with caution. For renal failure, you have to make sure your patients are doing well. You have to also be careful about the concentration of the medication in these patients, because they will take more time to be eliminated from the body. There's specific, of course, lab tests that I told you we have to start with and you have to follow the patient with. The most common side effects for them, more than 7%, is the worsening in the heart failure issue, hypokalemia, and atrial fibrillation worsening. So very important for us to instruct our healthcare professionals, our team, that you have to look at the patients, they need it or not. If yes, what symptoms are we looking for? When should we start beginning the DigiFab? The expected effect should be within the first 30 minutes. We have to make sure that the potassium level is monitored within the first 24 hours. The digoxin level also is monitored. We have to make sure that the patients are getting the proper monitor for their ECG. Toxicity level has been also monitored and measured. Very important for any tertiary hospitals or cardiac or even poison centers. They have to have a stock of Digifab just in case we need it. And according to the guidelines and according to the expert guideline consensus documentation, you should have at least 15 vial in stock. So when you need it for any patient, as we could see from the calculation, you can start immediately. Now, again, it's very important to mention the cost of this package. And you can see in Saudi Arabia, it costs about 7,350 Saudi Riyal, which tells us why we have to be expert when we are using this antidote. This is the team. You could see that as a pharmacist, we have to be there to help in the decision. Cardiologists are just nagging and give us a hard time. I want digoxin, I want digoxin. Now, Dr. Rawan has given us a very pleasant help, and she actually offered for us a toxicology consultation to help us taking the proper decision. But patient Hussam is really giving us a very good outcome and a very nice smile telling us that we did our job properly. Again, don't stop there. We have to start acting. We have to work together. I think this drug really is a very good, and it's a very nice chance for our patients to take care of if we are doing it properly in a teamwork. Thank you very much. So I think we have questions here, Dr. Rawan.
أول شيء يعطيك العافية دكتور فخر، يعني you elaborated حقيقي إنه في كثير أشياء جدا مهمة، في نقاط جدا it's not easy to tackle. قاعدة بشوف من ال questions في one question يمكن تكرر شوية اللي هو this is very valid. هل can we use hemodialysis in the toxicity when we have a digoxin toxicity? I would say ويمكن أترك المايك لك بعد إذنك بعدي إذا في have a comment. No. We don't treat the digoxin toxicity سواء في الأكيوت سواء في الكرونيك بالهيمودياليسيس لأنه it have a high volume of distribution and so we don't حتى لما you give the digifab same thing. ولكن saying يعني I'm saying not for the sake of taking off يعني يمكن لما نفكر فيها taking off البردن حق الديجوكسين it doesn't work this way. ولكن yes you will consider it for the other factors زي الهايبركاليميا زي الأسيدوزيس renal impairment يعني for the other normal indications for hemodialysis it يعني yes it will be help لأنه فعليا بالذات في الكرونيك actually حتى الأكيوت it is the supportive care we really need to supportive care للمريض من كل النواحي يعني it's not only about giving the digifab it's not only you really have to take كل النواحي الالكترولايتس عند المريض adjustment إذا في acidosis الهايبركاليميا كل الأمور هذه. But that's if I hope it answers the question. If you have a comment دكتورة
يعني I just want to
فخر yes.
just يعني clear a point also. هو dialysable. Digoxin, by the way, it's a dialysable medication. So maybe we might consider hemodialysis in some cases where it is resistant, because again, Digifab sometimes it will not work alone. It might need help. So that's why you have to decide before you give the Digifab. Are we going to do dialysis or not? Because Digifab by itself could be dialyzed. أنت كده you didn't do anything.
صحيح.
Another important thing is that why did we say 24 hours after the ingestion of or after toxicity happens? Because again, what happens, they will bind, but it's a reversible bind, which means if you don't remove it from the bloodstream, it will come back free again, it will work again. So this is very important for you to know that after you bind this medication has to be removed من الجسم. لو patient عنده renal failure, you are what happened maybe انت نقصت مثلا 50% or 60% of the medications, and you might not have extra vials of Digifab, and this is what happens sometimes in our center, because what happens, as we know, that we have like a stock of مثلا 15 vial, 20 vial, whatever, but I gave the first dose and already patients had renal failure. Well, maybe my patient will be exposed to digoxin toxicity again. At this time, I might consider dialysis. But زي ما قلتي دكتورة, and I agree with you 100%, it's not the first way to treat digoxin toxicity.
طبعا this brings the point اللي هو أساسا most of patients اللي أصلا هم they get liable أو susceptible للtoxicity هم نفسهم اللي هم high renal impairment because of the renal impairment اللي عندهم. فعشان كده حبيت to emphasize النقطة هذه إنه it is important for the patient.
كمان ترى بعض السنترز they don't have digibind يمكن
It
هذا
happened, yes, I did have one of the patients كان في لبنان المريض حقنا they don't have in the country لأنه it's not يعني we are lucky الحقيقة في السعودية we are
الحمد
lucky
لله.
إنه يعني حتى لو ما هو موجود في السنتر حقك ترى في ways وأمشي يعني حقيقة أنا my expertise مع الكلينيكال pharmacist كانت شيء خرافي من ناحية transferring الديجيفاب transferring whatever antidote أو هذا it is يعني it's the patient care فين ما كنت. فهذه من الأشياء الحمد لله نفتخر فيها وحقيقي يعني it's very لأنه واجهت cases I was consulted on كانت في دول في ما عندهم ديجيفاب they don't have it في الدولة كاملة. ف that's makes it very challenging في التريتمنت ومنها نبدأ we lean into زي ما ذكرتي الدياليسيس والأشياء الأخرى.
Great. في برضه هنا دكتورة concern I think it's very حتى الكارديولوجي colleagues في الراوندز بيسألوني دايما what do you mean by regular monitor of digoxin؟
يمكن أتركه لك هذه أكثر لأنه صراحة أنا يعني we don't really أنا بالنسبة لي ما يعني I'm sure you have more expertise أكثر في المونيتورينج أو دكتور كمال إذا كان موجود.
الدكتور كمال إذا موجود فعلا it's better خلي شوية بس نشوف هو موجود if not we can answer this question. برضو هنا دكتورة في ال diagnosis clinical sign of starting before toxicity before lab result أوكي
أيوه.
اللي هي شيء اللاب صح؟
I will say هم الكلينيكال إذا أنت ما عندك لسه اللاب ريزلت clinical signs not that easy بس إذا هي ما بتكلم على النوزي vomiting وما أعرف إيش لا أنا بتكلم when to consider very high toxic لما عندك arrhythmia that's not responding to the treatment يعني أنت حتبدأ التريتمنت يعني whatever سواء arrhythmia سواء bradycardia هدول الاثنين هم بالذات لما تكون life threatening زي ما ذكرتي دكتورة. لما تكون life threatening you will start the treatment زي ما احنا we know it سواء مثلا significant bradycardia life threatening you will start the treatment زي normally we do we go with the lines حقتنا atropine pacing plus minus keep it in mind إنه if you have resistant أو failing هنا وقتها إن أنت حتبدأ يعني you will keep it in mind. starting treatment حتى لو ما عندك الليفل لازم يكون في signs مو شرط إنه يكون الليفل موجود لأنه أحيانا ممكن يتأخر ممكن كذا يعني خلينا نقول resistant arrhythmias أو bradycardias definitely زي ما ذكرت يمكن في البرزنتيشن عندك ال cardiac arrest with a high suspicion هذه ما تحتاج مجرد عندك suspicion it is cardiac arrest you do your best في كل الأحوال.
which again that's why we always seek the experts يعني للأمانة أنا فاكرة حتى كان عندنا في الجامعي we always يعني سبحان الله في هذا patient specifically we always call each other ما يعني
صحيح.
you really need help لأنه في بعض patients which we faced ourselves هو chronic patients وعنده 0.9 ولا 1 وعنده sign and symptoms he's toxic he's having a toxicity so these kind of decisions أنا أعتقد محتاجة فعلا 2 opinion or even 3 opinion just
جدا.
to go to the proper side.
جدا صحيح.
الجزء حق المونيتور احنا usually what happens في الديجوكسين if your patient is stable especially بتكلم عن الكارديولوجي احنا عندنا الكارديولوجي for females it's 0.8 for الميل 1 يعني this is what we have been doing from our experience. So what happens a regular checkup is again like for example a patient are stable they come to the clinic every 3 months and there's no dehydration there's no kidney problem he's not above than 85 years old. In this case usually we ask them to do one every 3 months for example if it's stable ممكن أخليها كل 6 شهور بيعتمد على if there's any factors that need me to have extra monitor or not.
في سؤال هنا بيسأل على ال activated charcoal for toxicity. So في ال acute yes so it works it's actually activated charcoal works and حتى if you want to consider other doses ما يمكن عندي وجهة نظر بس يمكن كمان دكتور فخر إذا عندك وجهة نظر ثانية. ال activated charcoal yes it's ما بقول priority it works هل it works yes it does work ولكن keep in mind لما هدول المرضى you really want to consider the airway عندك and if you give an activated charcoal you're gonna complicate things بالذات لما يكون مثلا someone you plan to intubate someone you plan to so it's not the priority إنه I give activated charcoal هو يساعد yes it binds, yes you might consider بعدين multiple other doses it does لأن الديجوكسين زي ما ذكرت الدكتورة ممكن كمان بس كمان زي ما ذكرنا volume of distribution حقتك يعني ترى with time of ingestion هذه كلها تأثر على الافيكاسي. فأنا دائما أفكر على المريض نفسه إذا هو stable صاحي جالس is this time for أو خلينا نقول children اللي يكون أخذ incidental dose and جاء على طول immediately yes this is time to consider the activate charcoal. Once you have an airway to be considered as even as plan worsening يعني لما يكون عندك arrhythmia significant ingestion and you anticipate a bad outcome and you might intubate المريض to be honest I withhold مو عشان شيء بس لأنه priority is the air زي ما هي ABC في النهاية.
Yeah, I agree 100%. يعني أنا ما أعتقد أقدر أضيف شيء ما شاء الله يعني جاوبتي بشكل مفصل. يمكن جانا سؤال كده أنا صراحة يعني جذبني هذا السؤال دكتورة.
تفضلي.
يقول لك why do doctors limit the use of digoxin only to treat heart disease؟ يعني أدلك على إنه الناس ما شاء الله this is very good. Our audience
Yes,
are really
صحيح.
convinced now to go back and use it again. This is a very nice question. What do you think? Why?
يمكن I would not be the optimal person to answer. I just think it depends على guidelines عند الكارديولوجيست بالذات. That's يمكن هم لا لكن دائما ناخذ في consideration إيش الافيلابيلتيز اللي عندك إيش هذا لأنه yes you should not be طالما أنت عارف what you're doing زي أي شيء ثاني risk والbenefits حقتك لما تيجي تستخدمها يعني كترى part cheap part cost effectiveness part of إنه it does work we know it does work يعني ترى for يعني this is one of the old medications very proven ولكن why is it decreased هذا يعتمد على الجايدلاينز يعني societies والدول هذه I guess preference أحيانا حتى اللي ناس ما هم متعودين يعني أنا أشوف خلينا نقول different generations الكمفورت حقتهم في استخدام الديجوكسين أكثر من الجنريشنز اللي ما عمرهم استخدموا الديجوكسين طبعا ما حيكون comfortable لأنه ما يعرف له أو يشوف إنه complicated أكثر أو في options أحسن خلينا نقول أو عنده متوفر financial support so كلها تأثر على why it is used I guess أو يمكن دكتورة you have a different
يعني هو أنا كنت فاكرة كنا في الراوندز يقول له يعني especially اللي هم طبعا new generations أنا الميدل لاني من الأولد ولا من الجديدة يعني كنت I used to دائما يعني زملاء اللي أكبر أقول لهم أوكي يا أجري إيش رأيك نستخدم أقول له أوكي واللي توهم بادين أقول لهم أوكي يعني we should يعني decide with our experts should we use it or not. The most important طبعا killer كانت الديجوكسين اللي هي الستدي حقت اللي ذكرها الدكتور كمال in the beginning of the presentation. واحدة proven study واحدة اللي هو digital study اللي كانت they proved by a study إنها it increased the mortality. Now when you go and that time they shy away from using digoxin in cardiac patients. And then what happened later on when they were trying to get more data about this, they found that patients who are using digoxin, they are not monitored properly for their therapeutic level. This what made it more in the mortality.
Yeah.
We know that from our slides that up to 30% of the patients, they might be exposed to toxicity if we're not doing our job properly. So I believe this what shied away us from using it. Now, one study again showed again, talking about heart failure and atrial fibrillation, they told us that it will decrease the hospitalization of the patient and especially the less than 85 years old and patients who are having atrial fibrillation or heart failure with controlled beta blocker medication and so on. So these kind of specific group of patients, they will get the benefit. That's why it's back again with, again, the proper recommendations of monitoring it.
Yes.
Okay. I believe diagnostic of toxicity, Doctora, you did a great job here. So sorry. All the CME hours, all the questions that's related to the هيئة التخصصات الطبية, it will be answered by Kunuz Ritash. We cannot answer you that because they are the organizers. So please, Kunuz Ritash, if you can please answer our colleagues about this part. They are concerned about the CME hours, so we can take the scientific questions here. Now, what about activated charcoal? We already answered this. It's done already. دكتور عندك سؤال هنا؟
هنا فشايفة أسئلة كانت جميلة دقيقة فين راح في ما شاء الله أسئلة كثيرة we're trying just to take اللي هي نحاول عشان ما نأخر الناس. What other medications interact with the digoxin؟ يمكن ذكرها دكتور كمال.
Yes.
ما إيش في بالي ما في بالي comes to my mind الآن الأشياء اللي major الكونيدينز إريثرومايسين
Everything
ما
interacts with
أتذكر
digital.
أيوة في كثير أشياء بس يعني definitely to be
Even beta
careful.
blockers, even by the way,
بيتا بلوكر صحيح
even
صحيح هذه
amidorons, they
this
will
is the
interact.
worst amidorone صحيح هذه من الأشياء اللي very commonly known إنه you really have to be careful بس you really if you're planning to start the المريض أو he is on please always check the medications لأنه it does have lots of interactions فالسؤال حلو.
And that's why we do the monitor. يعني sometimes even these drugs might interact. So according to the patient's therapeutic levels, we can know that this interaction is, يعني sometimes we need a synergistic effect. So why not? We might have a lower dose of digoxin, and then we can give these two drugs together. That's why we do the اللي هي المونيتور حقت الليفل. في question هنا جميل. What happened if I miss a dose of digoxin? As simple as that. It's a chronic medications. Just wait, go to the next dose. And you don't have to replace it on the same day. Not like مثلا clopidogrel, not like aspirin. You can wait for the next day on the same time and take it on the next day. في رمضان كنا دايما we tell the patient, don't worry, we are not طبعا أكيد, I'm not here to advertise for يعني missing the digoxin doses, no. But if it happened, and it happens a lot, لأنه معظم patients خاصة وقت رمضان أو later on حتى it's a drug that could be missed anytime. So be careful not to miss طبعا one or two في الweek. هذه it's another story. I'm talking about a dose in a month مثلا. خلاص, don't take it this day, take it the next day. If you are the one of chronic misser زي ما بنقول لهم, in this case take it whenever you remember the dose.
في سؤال حلو كمان هذه very very clinically valid very is حقيقي من الصعوبات difficult. Is electric cardioversion safe in patients with the digoxin toxicity and severe bradycardia and low blood pressure? Difficult to answer. I cannot give you a definitive answer. ولكن في case reports تذكر إنه we fail the treatment, the regular treatment. يعني لما نتكلم على عشان كده بقول لك إحنا we start the regular lines of treatment الأريثمياس حقتنا لأنه it is life threatening موجودة عندنا ف we need to start treatment. لكن كتير case reports إنه if it is a digoxin toxicity it will fail. بعضها ذكرت إنه yes you want to be very careful when you use the cardioversion the dose اللي تستخدم يعني لأنه إحنا وذكرنا السلايد اللي حطيتها increased automaticity عندك أنت إذا بالذات لما تكون chronic it's very sensitive يعني الهارت تيشو عندك is very sensitive. cardioversion حتى البيس ميكر يعني كان في one case I remember case report كانت تذكر using transvenous pacing كان causing ventricular arrhythmias فمتخيل يعني أنت كل doomed either way. So you have to be very careful. I don't have a definitive answer. Yes, you will go with the regular ACLS guidelines حقتنا في life threatening. بس keep in consideration and you are dealing with a very delicate patient. His pumps are not, his heart tissue, they're very sensitive. Yes, you don't want to go like aggressively the super max dose من البداية.
في سؤال دكتورة يمكن هما two questions that I can answer them quickly.
تفضل.
في interaction with food, yes, there's interaction with food, and يعني هذه من instructions that we tell the patients always about the patient education. We transfer them to the clinical nutritionist. at the same طبعا you know that اللي هو heavy meals that are full of fat interact with the digoxin. And sometimes even you know that اللي هو العرق سوس licorice and يعني we always give a list of food interaction. So there is وكركديه والتفاصيل هذه لأنه again هو نبات by the way فيعني this could happen. Another thing phenytoin has an interaction or a role, of course. One of the very major interaction that happens, and that's why we try usually what happens, we start with phenytoin, we add on digoxin and follow the therapeutic level in order to make sure arrhythmia will not happen. And it's a very difficult arrhythmia to control after. So that's why the proper way to do, you start with phenytoin, because you know phenytoin is for seizures. And then you make sure that you're introducing digoxin gradually, so the interaction will be عشان نوصل a steady state of digoxin with phenytoin. So if you need طبعا to use it together. سؤال دكتورة ليكي هذا, is digoxin safe in pregnancy?
هذا مو ليه حيكون بس to be honest I cannot remember. I have to look it up. I'll have to check it up again. In the top of my head it doesn't come. I
Okay.
don't remember in the cardiology they use it in the pregnancy.
لا, we don't.
Yeah.
Although يعني برضو again we need a new reference for that. آخر study I believe it was like 30 years back where they said it's category C, and they said that it has to be even with caution, or sometimes even they say if you try to avoid digoxin. But on the other side, what's your other alternative is a beta blocker, which now we have good studies about it in pregnancy, and some of them are even at category B. B يعني safe, could be given for those patients. If we're using it for, again, for heart failure or atrial fibrillation, again, your other alternative is a drug that has a good studies, like labetalol, for example. It's a category B, so it's one of the drugs that could be given as an alternative. Rather than that, again, we need a new study to tell us where is digoxin now in pregnancy. Dealing with toxic dose of digitalis, I did not get the question. عندك دكتورة؟
ما شاء الله أنا قاعدة أحاول to catch up the other questions إذا في شيء
أنا
comment we're missing.
لأنه يعني please if you have any questions regarding the semi hours don't put it here so we can يعني نفيدكم في الشيء العلمي. الحين I think most of the questions has been answered. What most effective antidote for digoxin toxicity? What's your answer, دكتورة؟
ما أعرف كيف أجاوب السؤال لأنه يعني الدكتورة على الفخر يعطيك العافية جاوبتي بتفصيل ما شاء الله. What's the most effective to use antidote?
And again, phenytoin for, yeah, this is exactly the problem. Ahmed Jalal كان كاتب هذا الكومنت. Ventricular tachycardia. So that's why زي ما قلت لكم it has a very huge actually list of drug and food interaction. You have to be careful when you give it to the patient. Very nice question, دكتورة. Digoxin for critical ill patients in ICU. Do you expect the same response for those patients ولا لا؟
ما فهمت السؤال لأنه هل قصد ميادة هل قصد إنه to start to initiate it ولا to stop it ولا ما فهمت صراحة ولا لأنه في الكريتيكال definitely إحنا لكل لأن الريسك فاكتورز definitely لما يكون في الكريتيكال كير الريسك فاكتورز اللي بنتكلم عنها كلها حتكون موجودة. فإذا هو ما هو إذا هو سواء على digoxin أو is not I don't think it's the right time حتكون to consider. ولكن إذا ما أقدر يمكن ما فهمتها أنا بصريح
يعني
بشكل
لما ميادة ترسل لنا السؤال why use digoxin if other safer medication in renal impairment patient? Good question. I think دكتورة ميادة you have a point, you're right, but sometimes it's a good solution. We're not saying, as we mentioned in our presentations, even what was the second line or even had a third line of treatment, you're right. Yani this is important to consider. But it's a drug that we could use. So once we need it, for sure, it's a good drug to start. Best time to give it. And when is the best time to give it? Doctora, this is your...
شو best time to give what?
Best time to give digoxin. Digifab, I think is that Digifab, Doctor.
well to be يعني زي ما ذكرنا إنه في life threatening antidote we'll give it في life threatening arrhythmias that's not responding to the conventional treatment. هذا إذا كان فهمت السؤال صح. When to consider it. يعني كل اللي قاعدين نحاول نقول إنه it's not that easy. ما في 1+1=2. فكل اللي قاعد we're trying to relay المسج هذه إنه please consider كل الأشياء اللي ذكرناها. ما أقدر أقول 100% إنه like when to consider it كذا ولا كذا. في الأكيوت with a clear history زي ما قلت لك straight forward بالذات لما يكون hyperkalemia bradycardia life threatening kind of straightforward decision. other than that كل اللي بتذكروه هو فعلا هو يعني بيوضح اللي احنا المسج اللي قاعدين نقولها انه فعلا نحتاج فعلا تحتاج discussions تحتاج تفصيل كثير. how is the patient من متى بدأ على medication, how is the status of the renal impairment عنده من متى, هل other medications اللي بياخذها. كان في سؤال على الفينيتوين مرينا عليه في الفيتاك. I think في طرف انت جاوبت الطرف اللي هو الفينيتوين consideration if we need to use it. وفي طرف ثاني should we use it for the treatment of the VTAC. نرجع للنقطة اللي قلناها it can be considered. It is by logic yes ولكن I think I do remember case reports إنه it's not يعني not effective. خلينا نقول زي الاتروبين، نفس المثال القريب إنه إحنا مثلا atropine في bradycardia is effective، ولكن pacing same thing intracranial pacing. Once we use it, if you have a significant toxicity في digoxin, it will just fail. It will just not work لأن أنت بتتكلم عن cellular level that's poisoned. فهذا اللي يصير انه حتى الفينوتان يس ما بقول لك it's recommended, it's not a first line، ما حقول لك في الventricular tachycardia specifically اللي مع الديجوكسين ما بقول لك غلط، ولكن في case reports انه it didn't work، ف not the first thing to reach for، ولكن ما حقول لك خطأ. ف that's يمكن the best way to answer.
لأنه ترى يعني another part of this question دكتورة I think very nice actually. When does it end? الend الفانكشن حقه what time does it stop its function؟
اللي هو ايش؟
الديجيفاب.
I think هذا طبعا دكتورة فخر لك انت definitely. Well, how does it take على to work? How does it take to work and قديش نتوقع منه بعد كذا to last?
What we said in the slides, and I told you within 30 minutes, I'm expecting an action because again, as I told you before, you need to catch the free digoxin in the bloodstream. When does it stop working? Part of it يعتمد على the patient's criteria. If I have a renal impaired patients, for sure more than 6 hours, and for sure more than 12 hours, because the monitoring window is 6 to 12 hours. Why we did that? Because of the kidney function. So if your kidney is fine, your patient is doing good, I'm expecting that the action would be within 6 hours. But if I'm talking about something, again, part من الديجيفاب itself going to be excreted. So it's excreted with digoxin, you're fine. But if it's not excreted, I mean, it will stay for longer. How do you know? زي ما قلنا, you follow the lab results, you follow the signs and symptoms of the toxicity. This is where you know that خلاص, it stopped, you need another dose, or your patient is doing fine. And another good question here, Doctora, any recommendations for ICU nursing about patients on digoxin?
Well, that's very, very good question. يعني to be honest, the role for the ICU nursing is عظيم، ما هو شيء سهل. من فين أبدأ؟ أحس في المونيتور، في الإلكترولايتس، في not to start الكارديوفيرجن اللي عندنا لو developed arrhythmias، في الرينال impairment، في checking الميديكيشنز اللي الانتراكشنز، لأنه في كثير medications that could be missed by جميعا. ترى كلنا بشر لما بنشتغل، ف it's part of a team work كعموم. فكل هذه الأشياء I think it's definitely very important to keep it in mind في النيرسينج في critical care.
I think part of it also not to give the medications who interact with each other at the same time. So you should know which drug that interact to a part يعني do it in a part. دكتورة ميادة شرحت لنا بقى دكتورة
point my point about digoxin of other alternatives because of the long series of interaction and the cost of the drug and availability of antidote. Yes, هي بتشرح لنا. Yes, to be honest, دكتورة ميادة, yes, I agree. ما أقدر أحكم أحد why is he using digoxin or why is he not using digoxin. إذا كان هذه النقطة اللي بتكلم عنها ولا أنا نسيت.
أيوة.
it is.
Yeah, she's trying to say يعني why to go into this dilemma if you have other alternative or more safer.
البراكتس حق الناس مختلف، ما أقدر أحكم إنه like أنا اللي أشوفه كذا في هاي المكان. فأنا كنت بتكلم مع دكتور فخر أول إنه فعلا إنه في different practices، هي مو بس الجنريشنز، يعني هي بالسنين على التايم لاين السنين، وفي كمان في البراكتس الجيوغرافيكال اريا. ففي كثير عوامل تحكم why would you use it. هل هو خطأ؟ No, we would not. We just طالما you're aware of what you're using and ما بقول preference, it's more of ما ولا comfort حتى. It's more of what's available to you. Knowing the risk, knowing the benefit باللي موجود متوفر عندك، ما هو خطأ أبدا. فإذا ما أحتاج أستخدمه فعلا. نحن في البراكتس مثلا بقول لدكتورة فخر أشوف في قلة في البراكتس عندنا في استخدامه، فما هو كثير الإكسبوجر حقته، ولكن في الكونسلتيشنز أيوة بواجه كثير إنه ما زال مستخدم. فإتس لا هذا خطأ ولا هذا صح ولا هذا خطأ.
A question حقت renal impairment, I think it's an important question because yes, it's not actually half or يعني a quarter or 30%. It depends again on how bad is the kidney. And you have to calculate it according to the GFR. So your dose depends on your patient's GFR. This is the answer. For
Hmm.
digoxin preferred using, they are asking, which is, Doctora, this is your field.
IV digoxin preferable using in AF in ER only not to respond to another drug. So في cases yes digoxin like again it's not the first line to be used في especially في الأكيوت setting يعني في multiple عندك سواء rate control سواء rhythm control أنا بتكلم على ال first presentation في ال ER what you need to control the AF not the indications اللي هي ال chronic control. فيمكن هذا اللي يقصده راح السؤال الدكتور محمد أو أستاذ محمد. So
لا موجود
it's not the first line. أيوة it is not the first line. ما بقول preferable definitely. I have lots of other options to control. Plus إنه it takes time. يعني أنت بتتكلم أنت you need to control the heart rate. أنا من عندي واحد الهارت ريت 170. It takes time digoxin.
listen loading dose وبعد كده maintenance
بالضبط أيوة.
6 hours and another 6 and then another third يعني it's not easy to get it quickly, so you're right, this is not the preferable medication in the ER.
ما شاء الله الأسئلة في شيء أنا we're missing لأنه أنا أحاول إحنا we're over the time دكتورة فخر
we have
لك
5 more minutes just
بالضبط.
عشان برضو يعني our audience صراحة ما شاء الله تبارك الله very
أيوة.
active and I'm happy to know that.
الحمد لله الحمد لله.
يعني that means we really transferred الحمد لله the message.
بإذن الله.
If patient developed hypersensitivity, very nice question.
Very nice.
What is another solution for toxicity? Doctora, go
I
ahead.
did not face that. I hope I will never. I hope I'll never. فين راح السؤال؟ احنا بنتكلم.
لا أنا شفته بس هو بيقول إنه
قلتي.
لا 1 second يا الله. كان إيش السؤال؟ أنا نسيته.
هو أنا great shame hypersensitivity.
If your patient has a hypersensitivity to DigiFab, his question is what is the alternative? What are you going to do? And what is the other antidote for those patients? أو إيش هي solution in these patients?
السؤال يمكن حيكون I have to look into هل أصلا في sensitivity للديجيفاب. to be honest ما مر علي. أنا ما didn't face بس ما مر علي what happens. It's immunoglobulin so to be honest it's antibody sorry but I cannot I will say the regular what we do بالنسبة if your patient developed allergy and you think it is related to this you're gonna have to stop it treat the allergy consider recap everything with the team اللي معاك إيش الريسك إيش البنفيت لأنه في طرق أخرى كلها ذكرناها من ناحية is it really truly a toxicity ولا we are just dealing on a suspicion base. بس to be honest I really have to look into the base لأن حتى ما مر علي case reports في الشيء هذا. I have to look into هل أصلا في case reports على sensitivity to it أو لا. دكتورة فخر مر عليك؟
كان يحصل لهم أو what happened إنه they get allergy reactions, so what we do we introduce طبعا الكيت اللي هو الالرجي كيت and we continue with the antidote. ما حصلت anaphylactic shock منها. I didn't face this with my experience, but again it's like any other drug. There's an allergy and then other alternative اللي هو weaker alternative زي ما قلنا قبل كده اللي هو decontamination of the GI or the hemodialysis. It depends
صحيح.
on what options do you as an alternative to it do you have.
Nice question.
Small
Yes.
dose of digoxin for patients with paroxysmal atrial fibrillation without heart failure when beta blocker and calcium channel blocker are well, I think that's good. That's a very tricky question. And paroxysmal AF, again, rate control or rhythm control, which is the other dilemma again. Are we talking about small dose of an IV or a small dose of an oral?
في هنا السؤال يتفضل معلش أنا قطعتك آسفة.
زي ما قلتي دكتورة, it's not the first option, not the first line option for emergency. We're talking about emergency patients or what we're talking about paroxysmal AF. What stage is the patient in? And where's the patient? Is he in the clinic? Is he in the ER? So as an idea, it's not a bad idea, but again, it's not the first choice. But you have a patient who's failing to beta blocker and he cannot use the calcium channel blocker. So why not? Of course, this is your option in this case. Thank you.
هو الأميدرون traditional amiodarone is superior to digoxin in controlling a heart rate in critically ill patients, especially patients on catecholamine.
Okay.
Any comment?
عندك
any comment?
لا, you're right. هو عشان كده أنا بالضبط I don't know where is the patient. Yeah, if your patient is a chronic patient, maybe yes. Amiodarone, download. Again, you have to load the patient with it. Are they asking for loading with digoxin and then give another antiarrhythmic? يعني question ما هي واضحة. إلا أنها فعلا لها عدة أوجه في الإجابة.
يس لانه في قسمين للسؤال، حتى لانه واحد الاميدرون، وبالنسبه لي كونسيدر كاتيكومينز في جوابين هنا نفس اللي ذكرتيه دكتوره فخر، ولكن يس ما هي كونتر انديكيتد تو جيف ذا اميدرون. اتس اكشلي one of again زي ما ذكرنا من اللاينز اللي تستخدم احنا لما يكون عندنا اريثميا and we need to control it. ما بقول superior، بس يحتاج تفصل هل هو انت بتتكلم على acute chronic are we what are يعني هل هو to be for regular routine use ولا لا. هذه يمكن بروف كمال لو كان يعني حيكون أكثر في إيش البراكتس اللي يستخدم في الأميدرون. النقطة الثانية الكاتيكولامين special patients on كاتيكولامين. إذا أنت بتتكلم critically ill كاتيكولامين معناته patient is critically ill الآن with the suspicion of the toxicity. Catecholamines tend to have again لنذكر إنه tissue is very sensitive, so حتى using catecholamine should be خلينا نقول cautious. ما بقول again everything needs to be cautious. لو تلاحظ احنا كلنا قاعدين نعيد ونزيد انه very sensitive very delicate hard tissue very receptors عنده يعني جدا حساسة حتى للكاتيكولامينز. فهذه ممكن تذكر السيلولر حقت اللي حطيتها الصورة السلايد. لأنه الكالسيوم لما يدخل جنبه كانت في صوديوم بوتاسيوم ATPase، جنبها كانت الكالسيوم ريسبتور الشانل، جنبها كان حقت البيتا which تشتغل عليها الكاتيكولامين. ف
And I think
كلها
we have to run, Doctora. يعني thank you very much for all our audience. Honestly, we are
صحيح.
so happy to receive all these questions. Doctora Nadia Al-Muhtasib, we answered already the question that when a patient miss a dose, what to do, especially for chronic use patients. آخر سؤال dialysis, when should we start dialysis if you have no other option? But if you, whatever the level is, if you are looking for a level, dialysis is not your first choice. Digifab is your choice. Thank you so much for attending. Thank you so much, Dr. Rawan, for being our guest in the Saudi Heart Association webinar. It was a very successful webinar by all means. I'm so proud that we have this number of audience. So happy to talk about Digoxin from a pharmaceutical and a pharmacy and toxicology background. Very rich experience, Dr. Rawan. Thank you so much. Thank you so much, Dr. Kamal, also for the very important tips that you gave for our cardiology colleagues. Digoxin could be back again. Why not? Thank you for your questions. إن شاء الله بإذن الله نتمنى لكم رمضان مبارك. Thank you for attending. Today is إن شاء الله 10 من رمضان. Starting tomorrow إن شاء الله الثلث الثاني من الشهر الفضيل. أتمنى من الله سبحانه وتعالى يا رب ييسر الصيام ويقبل صيامنا ويعيننا على القيام. Thank you so much. And if we are interested in another webinar of Digoxin, please send for the Kunuz Retash for that. Our pleasure to be there. Thank you so much and see you very soon, inshallah, with a new webinar and maybe same topic, maybe another topic, but waiting for you to attend again. Thank you so much. تصبحوا على خير. في أمان الله.